Next up, we're going to
Hey,
hear
Tom.
from Bruce McIntosh. I'm excited to have Bruce as a faculty member, because Bruce has been in practice for about 30 years, which makes him more senior than I am. I'm very excited about that. And he's at Beaumont Hospital, and he's going to talk about, from a community surgeon perspective, building a robotic service line. Bruce is very savvy business-wise, and I always like hearing his thoughts. He's been innovative and early adopter and really pushing it. So go ahead, Bruce.
Good morning. Thank you for taking time out of your busy weekend to spend a little bit of time learning about how I help to build a robotic service line at William Beaumont Hospital, Troy. Troy is a community hospital, and I think you just heard a talk from George. I think you'll find that much of what I talk about will parallel what George had to do in an academic center to develop his service line, but there will be probably some nuanced differences, and hopefully between the two you'll figure out an approach that will work best for you. Here are my disclosures. So what are the barriers to entry as a robotic general surgeon? Access to daytime block. That's the thing I hear the most, is that surgeons are frustrated because they don't have access to the machine to do the good surgeries that they want to do. There are limited number of cases that can be done during a daytime shift, because what we define as a daytime shift is typically from 7 till 3:30, give or take, depends upon which hospital. How do we address add-on cases? That's a challenge. So this is for our gallbladders, for our incarcerated hernias, the things that we kind of need to do sooner rather than later. If all of the robots are busy with block cases that have been booked out for days or weeks, it's hard to get those add-on cases done. There's a resistance to change in the status quo from the staff and from the administration that can occur, and there are some pointers that we're going to give you to help work around that. The biggest problem is that robotics in many cases doesn't have a seat at the table. Decisions are being made by people that aren't robotic surgeons on behalf of the robotic surgeons in the robotic program, and this is something that will need to be changed if you're going to have any success. So what are the steps that you can do to create effective change? Create an inclusive robotics committee. I think a grassroots approach is very important. You're going to hear me say grassroots many times during this talk, because a bottom-up approach, in my opinion, works better than a top-down administratively driven approach. The rules need to be fair, equitable, and transparent. It can't be good for the urologist, but not good for the general surgeons, or vice versa. Then you'll need to gain access to administration. I have the very good fortune of having an administrative team at our local hospital that is awesome. They fully are supportive of what I do. A little side note, I had the opportunity to operate on one of the administrators in our surgery department, and they were scheduled to have an elective outpatient robotic surgery. They then came in on the weekend with an acute attack of biliary colic, and I explained that, look, on the weekend I don't have access to the robot, and so our options are I can do it laparoscopically on the weekend. Her symptoms had abated, and I gave her the option of going home and getting it scheduled for sometime during the week. She saw enough of value in the robot to say, you know what, I'll go home, I'll come back, because I think that's a better way of having my surgery done. So I had already had access to administration, but I think that you have to work through that and gain that. This obviously, she understood the value of robotic surgery, and I think we have to show that value to the administration so they can fully understand where we're coming from. Creating a team approach I think is important. If the staff want to be part of the team and feel inclusive, they're going to then work harder for you and be engaged. And therefore, I think you find your turnover times are better. You have a happier staff, and there are lots of surgeons around the country with all different types of service lines that are doing this, and I think uniformly it's to their success. Using that grassroots approach to problem solving, we shouldn't tell the staff how to do it. They understand way better than we do the nuances of their particular tasks that they need to do to get that next case going for you, or during the course of that case, and let them help you to figure out what the right thing is. I think that's a great approach to it always. So at Troy Beaumont, we have what we call the Surgical Services Executive Committee, and this came out of an older, probably 15 years ago or more. We had a consultant that came through that suggested a similar model in it. Like many times, these things come and go, but it really worked. And so we had a discussion amongst some of the surgical leadership and suggested that maybe we reinvigorate it. And we did that and formed the Surgical Services Executive Committee. Now, this is populated not necessarily by the chiefs or the appointed physicians, but high key stakeholders. Anyone in the Department of in the Department of Surgical Services can be part of this committee. It meets once a month, and it has multiple subcommittees underneath it, including the Robotics Committee, which I chair. And then that reports off to the Robotic Committee corporately. But also we have a blackboarding policies where we define who gets block and who gets block taken away. When it deals with our interactions with PAs, surgical use, which addresses the appropriateness of off hours, over the nights and weekend cases where perhaps there's some cases that are more elective that people are putting on and trying to get them done at 2 in the morning where we don't think it's the best thing. That ties into safety. Then our operating room leadership team then has underneath it the specialty teams, the turnover times, and CPD. The mission statement, I think, is one that at Troy we really believe, that is to develop and monitor fair, consistent, transparent, and reproducible rules and regulations to optimize safety, efficiency, staffing, and utilization in the operating rooms, with the guiding principle is that the patient is the center of all we do. If we keep that in mind, I think that people will agree. We have a very collegial hospital, and I'm very fortunate to have that, and I think that's what makes this work. Underneath the SSEC is the Robotic Surgery Committee, and there's the executive team, the executive committee, which is physicians from all or many of the specialties, colorectal surgery, gynecology, urology, general surgery, and then we have administration there as well. That reports off to the corporate robotic committee. We then have an administrative team that involves not just administrators and physicians, but also operating room nurses, physician's assistants, scrub techs, TSAs, CPD, pre-op nurses, all the touch points that those robotic patients will come across. Also then, we have all of the robotic surgeons meet on a scheduled basis. We initially planned to do that quarterly. It's been moved back to biannually, and this is an offsite meeting, and that allows everyone to get together, share best practices, share grievances, so we can work through things where everyone can be in a room together and work collaboratively. Through the robotics committee, we created some goals. We wanted to expand our hours of operation. Our struggle is that we run robots until 6 p.m. already, but we know that there are certain cases, cholecystectomy, I think, high on that list, where if they come in and you have a consult with them, and you might be on the add-on board where robots weren't available, you would have said, hey, we're going to do this laparoscopically. And then all of a sudden, if a robot becomes available and you're switching, I think you set yourself up for the patient saying, hey, why wasn't I getting this done robotically from the get-go? And conversely, if you say, we're going to do it robotically, but a robot's not available and you opt to do it laparoscopically, I think you set yourself up for potential complications and issues that way as well. So we are expanding our access until 11 p.m. Monday through Friday. We've trained the staff to do this, and so we're rolling out in a stepwise approach. There are other hospitals which have gone from doing it just during day shift to 24/7, 365. With our particular staff, I don't think that that's going to be the best model. So we're going to roll it out with the plan then as a second phase to add nights and weekend, or to add some weekend hours, and ultimately the goal to be 24/7, 365. We want to maximize our ambulatory center within the hospital. Some of you may have heard my talk about my freestanding ASC yesterday, but we also have an outpatient operating room connected to the hospital. It still bills as a hospital facility fee, but it's probably a little bit more efficient. we've moved one of our SI robots down there, and we're doing a lot of general surgery, cholecystectomy, inguinal hernias, and some hysterectomies with the goal of making those all outpatient. So we've developed an ERAS protocol for our hysterectomies, and we're trying to get some of those patients out same day. The third thing we're working on is, since the robotic team is a microcosm of the entire OR, we're working on some of the turnover efficiencies using that small, hopefully fairly motivated group to help us work through some of the processes so that we can get more efficient turnovers. And if we can make a more efficient turnover occur in a robotic room, which is traditionally considered to be a more lengthy turnover than some of the other cases, then we can apply those universally across the board to other types of cases and turnovers. So here's our meeting. So we do an offsite meeting once or twice a year. We apply them with food and beverage to get them to come, and then have a meeting where we have an initial group meeting with the whole group, and then we do breakout sessions, and we do this around, last meeting was around instrument utilization, so that we could quantify the number of instruments that each surgeon used, and within their group for a given surgery, they could then talk about, well, geez, I only use these instruments, and hopefully we're going to find that we streamline the process and reduce our I&A costs for some of these surgeries. So how do you address blackboarding issues? As a general surgeon, in most facilities, the general surgeons are doing about 50% of the cases. This is what's happening nationally, and I think happens at most hospitals. You'll need to know your hospital's service line robotic volumes by specialty. The gynecologists and the urologists tend to have the prime block time because they were here first, and when you're the only game in town, you get to pick your times. You need to demonstrate whether their volumes justify their block. If they're using their block all the time, that's great. If not, you'll need to establish rules to say, if you're not using your block efficiently, then some of that block should be taken away. I don't think it's an all or nothing, but perhaps you reduce the frequency of the block or the duration of the block, which will then open up more block for the general surgeons that can fill in. If people are using their blocks completely and efficiently, then it's probably time to consider an incremental robot. No matter what you do, you have to apply those fair, equitable, and transparent rules for your block allocation. Here's what we have at Troy. You can see the general surgeons do 49% of the overall volume, but that includes Mako robots because our robotic committee evaluates all different robots, Mako, Mazer, and Da Vinci. So if you take that out within the realm of the Da Vinci robot, we're well over 50%. So here's our rules for blocks at Troy. We have 4 robotic rooms, all that have block. Our block release for robotic cases for the surgeon is at 14 days. For that next week, between 7 and 14 days, it remains a robotic room and can be filled by any other surgeon who wants to use it for robotic time. After the 1 week prior to the surgery time passes, then it's open for any case to backfill into that room. We don't want the room to sit empty just because we're not using it for a robotic case. The exception is for GYN oncology, where we don't release their block until a week before. We then also send out a communication about any open robotic time 2 weeks in advance so that people know when some robotic block has been released so they can backfill those cases. We also, on our block committee, calculate the percentage of use of that case, including the turnover time, on a monthly basis. And if you're not using your block at least 50% on 2 consecutive quarters, we send you a gentle reminder saying you got to pick it up. If they continue to underutilize, then we reallocate that block accordingly. And that's all done with a committee, and it's all voted on and approved by the SSEC, the overarching governing body. The status quo, I think one of the problems is that everyone wants to follow the status quo, and the way around it is simply to create a different view of how we approach things, and that's this.
No man is more important than the team. No coach is more important than the team. The team, the team, the team.
So that's Bo Schembechler. And Bo, back in the 70s, gave that talk, and he was saying that, look, if we work as a team, we do way better than we do as individuals. And if we do that with our staffs and make our staff want to be part of that team, they're going to understand that the status quo won't work anymore. And so we create a team for the robotic surgery. We do team events. I do a pool party for the robotic team members and their families at my house every summer. Last year it seemed like there's over 100 people here. They had a great time. They felt included. They felt appreciated for all the hard work that they do. We also do other events over the course of the year. We include the staff members in the committee structure so that they're able to give their opinions, and we value their opinions on how we do things. That allows us an opportunity to educate the staff on the value for the patients to expanded access. They see the value of doing cases robotically and understand that to expand that out for the best of the patients, we have to get over the status quo. One thing that I do frequently is I call robotics laparoscopy 2.0. When I first started, and there was one lap tower that worked from 7 till 3 o'clock because only one person knew how to put it together. That time has changed, where now laparoscopy is ubiquitous. It's a 24/7, 365. There are lap towers literally on a boom in every room in our hospital. And I view robotics similarly. It may not be to that extent, but there will be expanded access. And when there's a pushback, I say this is no different than laparoscopy. And when you use that parallel, I think people understand it. So how do you get there? In my world, we start small. It's small, easy wins, and then work up to the big picture. So we expand block hours beyond a day shift. In our case, we went from block finishing at 3:30 to now 6 o'clock. That allows us to maybe do one extra case. For the urologist, I think that was a big deal when they were more limited and can do a couple of prostatectomies in a day. So now you can expand it and do more care for those block boarding cases, so you're not waiting 3 months to have your surgery. We then added limited add-on cases with a set cutoff time. So we're rolling it out with cholecystectomy to 11 p.m. Monday through Friday. That means you have to start by 9 so that my staff isn't spending a lot of overtime and getting home at 1 in the morning and having to double back. In time, we will expand those indications for the after hours robotic surgery, and we'll have to figure out what the next reasonable step is. Next step for us is plan on doing weekend hours for those emergent cases, and then expand the indications once the flow has been ironed out. And finally, our ultimate goal is to have robotics like laparoscopy, a 24/7, 365 process at our hospitals. So how do we get there? You have to have a team that's trained up. And that can be some small nuanced changes in how you educate them. It's a work in progress. We haven't got it all nailed, but I think we're really getting there. We've changed the new hire orientation to include robotics, and we do that towards the end of their rotation or of their orientation time. When they really kind of have got everything figured out, they spend a couple weeks in the robotic rooms. We've expanded our APPs that are trained in robotics. They're our lifeblood. We don't have residents, and so they're our bedside assistants, and they do an awesome job for us. We had a small cadre at first, and as we've expanded the number of robots that we have and the hours of operation, we've had to train more to really be facile at bedside robotic assistants. We're training existing staff that are non-robotically trained now. We're bringing them in to learn, and that's how we're going to be able to expand to do more cases after hours. We have some nighttime and midnight APPs, and they all are trained and oriented during the day shift, but then when they go to nights, they aren't doing as many of the high acuity cases that are fairly low volume. So what we're doing is we're rotating back onto the day shift for a month a year to specifically give them touches with those more high acuity cases. The AAAs, if they come in the middle of the night, those can be a potential disaster, but also to do robotics cases, because if the only way we're going to be able to do robotics cases at 2 in the morning when that incarcerated hernia comes is if they're ready to go. And to do that, we've partnered with Intuitive to help support those off-shift cases, and they certainly are helping out. So that kind of is my approach to expanding access in a community hospital setting. I would be pleased to now take any questions you may have, and thank you for your time.
Bruce, awesome job as always. Thank you for that. I definitely would echo a lot of your sentiments. I feel that most people come to work and they really want to do well, but if you can't measure their performance, it's hard for them to get really good feedback. So that's something we've tried to do, is really measure all the stakeholders' performance, whether it's turnover, pre-op, all the different things. My question is, how would you advise a new program around block time? How would you suggest starting out a greenfield account with allocating block time?
I think that the first thing you need to do is make sure that some time during your OR schedule is open for those people just starting. From a business standpoint, it doesn't make sense to give the newbie, a 4-hour or 8-hour block when they're only using it a small percentage of the time. So we keep a certain amount of our robotic block open, and then anytime someone relinquishes their block, we've got a 1-week gap between the time that we release it as a robotic block until we release it to any available surgeon. And so there are opportunities for those people that are newer to get going. And once they get going and they establish a track record that they're going to have utilization, then we look to get them into their own formal and dedicated blocks. The challenge becomes when you're running at 100 to 125 cases per robot per quarter, there's not a lot of room. And so we are now negotiating and looking at novel ways of gaining more capital. And I think that there are many hospitals around the country that are doing similar things. Intuitive is working with us, and it's now just getting our administration to wrap their arms around it.
That's great. Let's bounce it around. Elisa, you got something?
Yeah, great talk. So my first question, you kind of commented on block time, and it's inevitable, right, that some people are going to be upset by changes, but there's also people that benefit. So overall, how would you say that all of these changes, like how the surgeons have reacted to it? Has it been positive, negative?
I think because we don't do anything without fair warning as far as, taking away block, they have plenty of time to get their numbers up. I know Dr. Stifelman talked that he only gives them 1 quarter. We give them 2 quarters to get it together before we start doing it. And then it's not all or nothing. So we're going to just pull it back. If they have weekly block, we might make it every other week. Depends upon the type of cases that they're doing. Some people are doing longer cases. And so if you shorten their block down, they can't do anything. We have a good collegial department, and I think people understand. And the people that are underperformers, they know they're underperformers, and they might get mad and they take it away, but they really have no argument. And if you apply the rules equitably across everyone, I think that they don't have a leg to stand on when they complain.
Great. Also, I think we can all certainly relate to culture changes and fighting the resistance, especially with this particular topic. Obviously, you've been very successful in fighting that change and getting to where you are now. Can you give us an idea of how long it took before you got to a point where you really felt like you had a strong 24/7 access available?
We're not at 24/7 yet. We're doing a little bit different model. I know that some of the other hospitals, I think Hackensack did it they jumped in with both feet. Many of the other hospitals done it that way. With our particular surgical staff, it just wouldn't work. I mean, I think that I would rather have wins and defined wins in short segments rather than trying to go all in and not having all the success we'd hoped for right away. So we're doing it in a rolled out in graduated manner, but we have a kind of a path going forward. And I think that model has worked better for us at Troy. I think every hospital is different. It depends upon the underlying culture of the hospital and the eagerness to learn and the ability to train them, because it doesn't do you a lot of good. I have 500 people in surgical services. To train them all at once, they wouldn't get enough touches on the robot to remain proficient. And so I think that was one of the reasons we chose the more graduated approach.
That's great. I think it really highlights that there's, it doesn't have to be an all or nothing. Then you can certainly work your way up to where you want to be. I know a few of our other presenters are still on and they have some comments. So Dr. Stifelman, did you have something to add?
Mike, I think you're muted.
While he's unmuting his mic, over there. There we go. Dr. Stifelman?
Can you hear me now?
Yes.
Yes.
Super. The Verizon. So 2 comments. I think I agree with Bruce. And the reason I think we are successful with going to 24/7 is because we already expanded the access during the week. So many of those night people were coming in at 3 o'clock and doing 2 or 3 more cases, literally. So they already had that experience. So I agree, getting that graduated approach is really kind of what we did. The second comment I want to focus on is block time. So I think like Bruce did, and I think what we do is it has to be very transparent. These are the rules. This is how it's going to work. The one thing we did has been extremely helpful is that we made it by service line. So basically we distributed, this is the 10 days a month of that we're giving to general surgery. And you guys need to figure it out. And so one of the things that's been very successful every 3 months when we meet is we look at, if you're only doing 2 cases a day and finishing at 3, having 4 days a week, we'll sort of consolidate you to 3 cases per month, 3 days a month. And so you can do 3 cases each day. So we're always looking at the white space and always looking at ways to consolidate people. And the last questions come up a lot is, well, how about for the new surgeons? How about for the surgeons who aren't as efficient? I can do 4 prostates and be done by 6, and they only do 2 prostates and they're done by 6. How do we manage that? And the way we look at that is if you're beyond the standard deviation, 1 standard deviation in operative time, our first goal is to help you. We spend 3 months or more helping you. We send you to courses. We actually will go and proctor you and scrub in with you. We will get you on the simulator. We will share our videos with you. We have CSATs with you. And at that point, we've noticed that people actually do get better. And we've really not had to take some privileges because of that. And we've seen some amazing success stories. And that's sort of the last point is your division heads who run this, the people in general surgery, the people in GYN, they need to be altruistic. It's not about, oh, you're terrible, we're taking time away. It's got to be about, let me help you get better. And after you make that effort and it doesn't happen, that's a different conversation. But I think it's that sense, that camaraderie around the program that we're all going to help each other, again, raise the tide, is the approach that has worked in the institutions I've been at.
I agree totally, Mike. It's the team, the team, the team. That's been a mantra I've used since I've started doing talks for Intuitive 8 years ago. I think that there's value in that. And if everyone really buys into that, and we're fortunate that people do, we'll help you. We will help train you up, as you mentioned. And the other thing we do is that on our offsite, we show people their individualized data. We can't show it in an unblinded manner, but everyone knows where they stand relative to everyone else. And surgeons are by nature competitive people, and no one wants to be at the bottom of that list. And they will make themselves better. They will ask, hey, everyone figures out who the slow people are because already.
Yeah.
And so that moves them up, and that's a self-motivator as well. And I think that has worked well. We've used it for INA, especially in GYN. There's a large variation in number of instruments that are used in a case. We showed them that data, and we're hoping to publish that when we bring it back at a year to show the improvement by that blinded method. That was at an offsite meeting where they sat down at a table and it's like, hey, what instruments do you use when you're doing a hysterectomy? This is what I use. And that grassroots effort, George and I have used the same words during our talks, and we had never met before, these events. So individually and independently, we've come up to say the same thing. So I don't know if it makes any difference that you're in an academic center. There's probably some differences, but not substantial. Academic, community-based, they're all the same. The same kind of concepts ring true for all of us.
Excellent. I agree.
Great comments from everyone. We really just have a minute here. George, I know you had a comment as well. Care to add?
Yeah, as well, Dr. McIntosh just said it. We all had similar words in our presentations, and I never met him before. And I think that really alludes to we have a common fight at different situations. We all end up having the same result. So, Dr. McIntosh, why do you think we did have the same words in our presentations without even meeting?
That's a really good question, George. I think that the answer is that no matter what you're doing, your mom taught you treat people nicely and you'll be treated well. That holds true in everything, including surgery and everything else you do in your life. If you're nice to people, if you include them, they feel included and they're way more motivated to help you than when you say you have to do this because I tell you. And I think that it shows that your mother did a good job with you.
I think it just means that you guys are brothers from a different mother. I mean, that's kind of what you just said, right?
Absolutely.
Awesome.
I agree.
All right. Thanks again, Bruce. Let's move along in the interest of time.